All right, why don't we get started? Good morning and welcome to Medical Grand Rounds. Today is our case conference, which will be done by the hospitalist group, and you can see the title and the presenters there being displayed. Our rules are the usual rules, so only the panelists will be able to share audio and video. The Q&A button at the bottom of your screen is the place to ask questions. You can ask the questions anytime you want during the presentation. I will try to put them together and ask verbally the questions either at the end or along the way, depending on how appropriate they are. There are 3 slides during which we will be doing audience polls today. So be prepared to participate in the polling. It looks like we've gone up to 60 participants at this point. So we're going to go ahead and get started.
Okay, thank you, Dr. Fatak. Good morning, everyone. Welcome to this morning's Grand Rounds. I'm here with my co-presenters and colleagues, Dr. Kumar, Dr. Verghese, presenting syncope, and it could be a very challenging clinical scenario in the inpatient or outpatient setting. And I'll be starting out by presenting 3 cases. Like Dr. Fatak said, we have a poll. So we'd like to interact with you, get your views about if you admit or discharge these patients. So we'll go straight to the first case. And it's a case of a 72-year-old male with a history of thyroid disease, prostate and bladder cancer, status post urostomy, atrial fibrillation and Eliquis, congestive heart failure, AAA, and morbid obesity, who presented to the ED with complaints of visual disturbance and loss of consciousness. He had had poor oral intake for the last 26 hours because he was trying to lose weight, and his PCP recently started him on a weight loss pill. His girlfriend states he was going to a restaurant to grab takeout when he passed out in his driveway. There was loss of consciousness for about 2 minutes, no urinary or bowel incontinence, no convulsions, and luckily he did not hit his head. He is retired and lives with his girlfriend. He ambulates with a cane at Baseline, and family history is notable for coronary artery disease, CVA, and heart failure. Home medications include Eliquis, metoprolol, Bumex, and levothyroxine. Vital signs: blood pressure was mildly elevated at 150/80. Heart rate, he was tachycardic at 110. Normal temperature, normal respiratory rate, and he had negative orthostatic exam. Physical exam: elderly male, tired appearing, but not in acute distress. He had clear breath sounds bilaterally. He had irregular heart sounds and was tachycardic. His urostomy was filled with dark urine, and he had chronic venous stasis changes with trace bilateral pedial edema. Workup: blood work was unremarkable. Troponins were negative ×2. His EKG showed atrial fibrillation with a rate of 120, no ST, QRS, and QT changes. Chest X-ray was negative for acute disease, and his CT head was negative for intracranial pathology. So would you admit or discharge this patient?
Our number of participants have gone up to 75. So I'm just going to do a quick audience poll first to see who's participating, and then we'll answer this question: would you admit the patient or not? So which of the following describes you best? And I'm going to launch the poll now. Okay, so those are the results. We have, as usual, a mix of people, residents, specialty physicians, hospitalists, primary care physicians. So I am now going to launch the question, would you admit this patient or no, send the patient home? Okay, about half the people voted, and here are the results. So 80% would admit this patient.
So we'll go to case 2. The case of a 95-year-old male with a history of CAD, status post cabbage, second-degree heart block, status post permanent pacemaker. He also has a bowel prosthetic aortic valve. He has a history of hypertension, hyperlipidemia, and diabetes, who presented with syncopal episode. He was found to have slumped forward while having breakfast at the dining table. Loss of consciousness was for about 3 minutes, but regained consciousness prior to EMS arriving. Patient reports he had some chest pain, palpitations, and lightheadedness before passing out. He had no urinary or bowel incontinence. Vital signs, he had positive orthostatics. His blood pressure laying down was 160/90, sitting up was 140/80, and standing up was 110/60. Other vital signs were normal. Physical exam, he appeared uncomfortable. Chest exam, normal breath sounds bilaterally. Cardiovascular, he had a loud click with a murmur. No edema, and he had palpable pedal pulses bilaterally. Neurological exam, he was alert unoriented ×3 with no focal deficit. Workup, his blood workup was essentially normal except for his first troponin, which came back to be 0.9. EKG had no ischemic changes, and chest X-ray showed trace bilateral pleural effusions. Would you admit or discharge this patient?
Okay, again, about half the people voted, 91% would admit him.
Okay. Okay, and now the third case. 30-year-old female executive with a history of anxiety presented to urgent care with syncope. Her husband reports she was in the bathroom when he suddenly heard a loud thud. He ran in to help her and found her on the floor next to the toilet. She gives a history of constipation for about 4 days and poor fluid intake for the past 2 days. Denies fever, shortness of breath, or chest pain. Her family history is significant for sudden cardiac death in her dad at the age of 40 and breast cancer in her mom. Medications include Buspar for anxiety. Vital signs, blood pressure was normal at 110/80. She was mildly tachycardic at 105, and all other vital signs were essentially normal. She had negative orthostatic vital signs. Physical exam, anxious young female with clear breath sounds, S1, S2, she was tachycardic. Abdomen, musculoskeletal, were essentially normal, and she was alert and neurologically intact. Workup, a blood workup was unremarkable. EKG showed sinus tachycardia with no other changes. Would you admit or discharge this patient?
Okay, people are more comfortable voting, and we got 48 people voting with 3/4 saying discharge the patient.
Okay, so I'd like us to take note of these cases because we'll be coming back to them later. Dr. Kumar will be discussing syncope along with some current guidelines, and Dr. Verghese will talk about some risk stratification scoring calculators, which would apply to the 3 cases later on in the presentation. So I'm going to hand over to Dr. Kumar.
All right. Good morning, everybody. So let's continue our talk. Basically, in our talk today, outline will be on starting. I'm going to start with some of the definitions and epidemiology about syncope, and then we'll discuss some of the causes and differential diagnosis of syncope, and then focusing on some guidelines, and then risk stratification and scoring systems. And at the end, we're going to come back on cases and then summarize our talk. So we're not going to talk about in detail about management of syncope during our presentation today. So what is syncope? Basically is a symptom characterized by an abrupt and transient onset of complete loss of consciousness and associated with inability to maintain postural tone, and also characterized by rapid and spontaneous neurological recovery without requiring any resuscitative efforts. And the mechanism of syncope is cerebral hypoperfusion. Now, the clinical features of other non-syncopal causes of loss of consciousness should be excluded in order to diagnose as syncope. And loss of consciousness, by definition, is a cognitive state in which one lacks awareness of one's situation and with an inability to respond to stimuli. So it's important to note here that not all loss of consciousness is syncope. And which is obvious from this approach, that how we approach patients with transient loss of consciousness. Basically, it is characterized into 3 different types. Traumatic loss of consciousness, likely due to concussion. Non-traumatic loss of consciousness, either due to syncope, seizures, some intoxications, and other metabolic problems. And there are not true pseudo loss of consciousness, likely due to psychogenic effects, drop attacks, and epilepsy. What is pre-syncope? Basically, it's a constellation of symptoms before syncope, and that could progress to syncope, or it could abort without leading to full-blown syncope. And those symptoms include extreme lightheadedness, visual sensations like tunnel vision or graying out, and other vagal symptoms like nausea, vomiting, having urge to have a bowel movement, and associated with variable degrees of altered consciousness without complete loss of consciousness. And orthostatic hypotension essentially is defined by systolic blood pressure of loss of systolic blood pressure of equal or more than 20 mm of mercury, or diastolic blood pressure of equal or more than 10 mm of mercury, with assumption of upright posture from sitting or lying posture. Now, few things about epidemiology of syncope. Essentially, lifetime prevalence of syncope is somewhere between 10.5% to 19%. And in United States, 1% to 3% of all ED visits are related to syncope, and 1% of all hospital admissions are actually related to syncope. Approximately 35% of ED syncope visits are admitted to the hospital. Now, this number is substantially greater than what is essential, and recent efforts have been there directed to reduce these admission rates, and we're going to discuss about that in detail later on. Incidence of syncope is essentially bimodal, with the first peak in late adolescence to early adulthood, and then later peak, second peak in the older age, especially after 70 years of age. And incidence is slightly higher in females compared to males. Syncope essentially is classified into 3 main categories: neurally mediated or reflex syncope being the most common cause, about 45%, then cardiac syncope, and then orthostatic hypotension related syncope. Despite of extensive workup and extensive management, So about 25% of patients presenting with syncope remain unexplained or undiagnosed cause. Neurally mediated syncope, some of the common causes being carotid sinus syndrome or carotid sinus hypersensitivity, when our carotid sinuses are overly sensitive to the stimuli. Common examples being patient losing consciousness after shaving or tight collar, something like that. And other causes can be situational, like syncope brought on by coughing or defecation or other visceral stimulations. And vasovagal syncope, the most common cause of reflex syncope, started by any extreme fear or pain stimulus or significant stress. Let's review some of the basic anatomy and pathophysiology of our baroreceptors. What are these? These are essentially stretch-sensitive mechanoreceptors located in posterior inferior wall of the heart, vena cava, carotid sinuses, and aortic arch. And the afferent fibers from these receptors go to the ventrolateral medulla, where basically they modulate the autonomic nervous system output, and the efferent fibers from there come out and supply the cardiovascular system. Let's review basic pathophysiology and mechanism of reflex syncope. So starting with either prolonged standing or strong emotions or any visceral stimulation ultimately leads to peripheral vasodilation, which leads to decreased blood return to the heart. And in exchange, heart contracts vigorously against decreased amount of blood, and that stimulates baroreceptors. That's the first stimulation of baroreceptors. That signals to CNS to preserve the cerebral perfusion through decreasing the vagal tone and increasing the sympathetic tone. Now that ultimately leads to increased myocardial contractility against relatively underfilled ventricles because of the peripheral vasodilation. Now this is a common phenomenon in a lot of people, and most often it stops there, but in some cases the response is exaggerated. And in response to that, intracardiac baroreceptors are paradoxically overstimulated. And due to that overstimulation, second reflex starts characterized by increased vagal tone and reduced sympathetic tone. That leads to reduced heart rate, reduced peripheral vascular resistance, and global reduction in cerebral perfusion, leading to syncope. Now, often these patients will present with vagal symptoms, autonomic symptoms like a headache and sweating and sense of cold or warmth and so on and so forth. Cardiac syncope can be because of multiple reasons, most commonly arrhythmic causes of any significant arrhythmias, obstructive cardiomyopathy, structural heart disease like acute MI or arrhythmogenic right ventricular cardiomyopathy, infiltratory diseases, and other structural diseases of cardiovascular system like aortic dissection, cardiac mass, cardiac tamponade, pulmonary hypertension, and cerebral pulmonary embolism. Orthostatic hypotension-related syncope can be due to multiple reasons. Again, drug-induced cause is very common in our elderly population due to polypharmacy, postural tachycardia syndrome, primary or secondary autonomic failure, secondary to multiple neurodegenerative diseases, and then volume depletion, obviously, because of multiple causes, acute blood loss, bleeding, or multiple other reasons. Now, of all the types of syncope, cardiac syncope has the worst outcomes compared to other causes, which has been studied multiple times, and I'm going to quote a few of them. Kapoor et al. Studied the patients with syncope for about 5 years, and they found 5-year mortality, which was significantly higher, about 50% in patients who presented with cardiac syncope versus non-cardiac syncope patients. And the incidence of sudden cardiac death was also significantly higher in patients with cardiac syncope compared to non-cardiac or unknown causes of syncope. Unger et al. Studied patients of syncope for 2 years, and they followed total 2-year mortality. They found about 9.2%. And as you can see, more than 80% mortality was in older patients with cardiac fractures, abnormal EKG, and history of a structural heart disease, or patients who sustained severe injuries related to syncope, versus in patients without any abnormal EKG or structural heart disease. And similarly, Numeroso et al., they studied cardiac syncope patients, and they found greater short-term and long-term occurrence of at least one adverse event in patients who had cardiac syncope compared to non-cardiac syncope. So this table basically, we often come up with the clinical scenarios when we have patients present with the unwitnessed loss of consciousness. We confused about whether it's a syncope or epilepsy. And also, it may worth to mention here, a lot of patients having actually true syncope, they do have myoclonus, and it makes the situation and diagnosis even more difficult. So few things to keep in mind to differentiate between true convulsive syncope versus seizure. So the myoclonus in actual syncope, true syncope, is usually follows after the loss of consciousness. Or in contrast, in seizure, the myoclonus will be immediate or during the loss of consciousness, or even before the loss of consciousness. High deviation has to be seen upward in syncope patients compared to lateral in seizure patients. And the rhythm is arrhythmic, usually in syncope patients, as against to seizure patients. And the pattern of myoclonus is usually multifocal, proximal muscles, as compared to unilateral or more formed neuroanatomic evaluation or generalized tonic-clonic behavior in patients with seizure. Duration is pretty short in patients with syncope, lasting for 1 to 15 seconds compared to 30 seconds to 2 minutes in patients with seizure. Urinary incontinence can occur in either case. This is important, I think, to remember, since as the definition of syncope says that it is complete neurological recovery. So there should not be any post-ictal confusion, but patient can complain of post-ictal fatigue compared to patients with seizure. Another common scenario we come across to differentiate between true syncope from pseudosyncope, and neurally mediated syncope being most common. A lot of patients will present with true syncope with vagal symptoms, as I already mentioned, and also with myoclonus, but those are not seen in patients with pseudosyncope. Eyes open in patients with syncope compared to closed, and the motor activity can be decreased, often decreased in patients with syncope compared to pseudosyncope. They can actually move their extremities against resistance if you examine carefully. Duration is again short in patients with syncope of unresponsiveness compared to in patients with pseudosyncope. And blood pressure might be decreased, and EEG may show depressed, suppressed background activity in patients with syncope compared to normal or increased artifacts. And again, as I said, with some vagal symptoms in patients with true syncope, but patients with pseudosyncope will have continued or prolonged semi-responsiveness. Now let's review some of the basic guidelines from ACC/AHA. These were the last updated in 2017. Just a reference table, how they present their recommendation from class 1 to class 3 being higher risk than benefit, and where the level of evidence is coming from, either from the randomized control trials or non-randomized trials or something. So general principle is any patient who presents with some sudden loss of consciousness, if you suspect syncope, start initial evaluation with a detailed history and physical exam, which should include the orthostatic vital check and EKG. This is a class 1 recommendation from ACC. And then if cause of syncope is sudden, then you can go on the treatment. Along with initial evaluation, we have to risk stratify our patients who is at high risk or low risk or moderate risk. Now, initial evaluation, again, on the same ground, we should include, history should include activity and postural tone before the event, and what were the precipitating factors, any prodromal symptoms, prior history of similar events, past medical or surgical history or family history, and medications more importantly. Again, physical exam always should include orthostatic vitals and go on EKG. Now, again, from the guidelines, history and physical exam and EKG is class 1 recommendation. We should always include in patients with syncope. And risk assessment is class 1 recommendation. We should assess the risk of patients for the assessment of short-term and long-term morbidity and mortality risk. And it's worth to mention that from ACC 2017 guidelines is class 2B recommendation that use of risk stratification scores may be reasonable in patients with management of patients with syncope. Coming on the blood testing, it's class 2A recommendation to do targeted blood test on patients who, based on their symptoms of presentation and EKG findings. Class 2B being BNP and high sensitivity troponin measurement was uncertain as of 2017 ACC guidelines in patients who presented with syncope. And worth to mention that routine and comprehensive lab testing is not useful in patients who present with syncope, suspected syncope at least. And on the same grounds, any patient who comes with loss of consciousness with suspected syncope, routine imaging of the brain with MRI or CT is not recommended in patients in the absence of focal neurological findings or any severe head injury that supports further evaluation. Now, after the initial evaluation, how do we determine where this patient should be best cared for, like whether inpatient admission or needs outpatient evaluation? Now, for that, we have to look for serious medical conditions as per ACC guidelines. And what are those? We have to look for some sustained or symptomatic VT or serious cardiac arrhythmic conditions. If the patient had those, or any presence of pacemaker or ICD malfunction, or any cardiac or vascular non-arrhythmic conditions like cardiac ischemia, severe aortic stenosis, hypertrophic cardiomyopathy, or pulmonary embolism, and something like that. And serious non-cardiac conditions like severe anemia, GI bleeding, abnormal vital signs, and major traumatic injury due to syncope. So if we find serious medical conditions during initial evaluation, then suspected patients with syncope should be admitted for inpatient evaluation. Now, if any patient who does not have any serious medical conditions and the presumptive cause of syncope is reflex mediated, as per ACC guidelines, those patients can be safely discharged outpatient and their workup and management will be on outpatient setting. And for patients who have some intermediate risk factors like no serious cardiac disease and absence of serious medical condition, those patients can be best suited for ED structured or observation protocols and can be admitted under observation rather than inpatient. Now, worth to mention here, so some patients who present suspected cardiac syncope, as we mentioned, the cardiac syncope has worse outcomes compared to non-cardiac. Selected patients suspected with cardiac syncope can also be managed in outpatient setting. Now, how do we decide about those patients? That is kind of something we're going to discuss in detail later on today. And on that note, I'm going to leave next to my colleague, Dr. Verghese. He's going to start presenting some investigations and other research. Thank you.
Thank you, Dr. Kumar and Dr. Adunse. Good morning. So we have got a brief outline so far. So what are the main challenges we face with syncope? Syncope is a very challenging symptom for the first contact provider, the patient who sees the patient first. Because by then the patient has usually recovered. There are no clear physical findings. As outlined before, the differential is quite vast. And the patient or the witnesses may not clearly recollect the detailed historical findings. The time availability in ED to undertake a detailed assessment is limited. And there's always a physician concern for patient safety after discharge. So in a study that was done by Bartoletti, they examined what were the admission rates in the ED with syncope. So they evaluated a total of 1,100 patients, and they used, this is a European study, so they used the ESC guidelines. And based on the guidelines, they felt that about 400 of them met the criteria for admission, and about 60% of them did not meet any criteria. But the actual admission rates for this set of patients was close to 90%, and 25% of them did not meet any criteria for admission according to the ESC guidelines. This was also similarly seen in another study, it's called EGS-YS2, and we'll come to it later today, that the admission rate was close to 39% despite having expert online assistance to the frontline physicians that was given to these ED providers. They also did another study to see how good was physician judgment when it came to determining predicting serious outcomes for patients with syncope. And they found that the sensitivity was about 100%, but a specificity of only 30% to predict serious outcomes at 7 days in cases of syncope. So this has always led to the topic of developing clinical decision rules and various risk assessment tools to help the ED providers to help a decision reaching on syncope. So one of them was just initially used was known as the ROSE rule. It's a risk stratification of syncope in the emergency department. It is an ED-based single center study done in Edinburgh, UK. And it was done to assess the risk factors to predict an adverse event within a month of the patient presenting with syncope. The various criteria that they used in the scoring system was a BNP more than 300, a positive fecal occult blood test, hemoglobin less than 9, oxygen saturation less than 94%, and the presence of a Q wave on the presenting EKG. From their scoring system, they had a sensitivity of about 87% and a specificity of about 65.5% for predicting a serious adverse event. This study was not validated either internally or externally. Then came the Boston study. The Boston study is one of the 2 studies that were done in the US. This had about 293 patients that they followed 30 days after they presented to the ED with syncope. The adverse events they looked at were death, serious illness that required a hospitalization or any acute intervention. The criteria that they used in their scoring system included signs and symptoms of ACS, conduction disease, any worrisome cardiac history, valvular heart disease by history of physical exam, family history of sudden death, any persistent abnormal vital signs in the ED, volume depletion, GI bleed or a hematocrit less than 30, or any primary CNS event. They had a sensitivity about 97% and the specificity about 62%. But again, the results of this study were not externally validated. Then we had another European study known as the STEP study, is a short-term prognosis of syncope. They had about 676 patients. They assessed adverse outcomes within 10 days of initial presentation with syncope. But the problem was that they had a very low positive predictive value of only 11 to 14% because they had a very low rate of adverse events. And again, the study was not validated. The San Francisco syncope rule is a very popular tool that was used for syncope. It was developed in the ED of the University of California at San Francisco. They had 791 consecutive visits, patients that presented with syncope from July 2002 to August 2004. And basically, they called out for congestive heart failure, hematocrit less than 30%, a presence of an abnormal EKG, any shortness of breath symptoms, or systolic blood pressure less than 90 at the time of triage. This had a sensitivity of about 96% and a specificity about 62%. And in the validation cohort, it had a sensitivity about 98%. And it boasted a higher specificity than physician judgment with a specificity of around 56%. And it estimated that the use of this scoring system would reduce the overall admission rate by about 7% if applied accurately. But this study had a lot of limitations. There were no serious clinical outcomes that were missed, but many low-risk patients were unnecessarily admitted to the hospital despite using the rule. The validation studies that were subsequently done by Birnbaum et al. In 2008, they were not able to replicate the high sensitivity. The study found that the rule actually had a sensitivity of about 74% and a specificity about 54% for predicting serious outcomes at 7 days. The original study misclassified some of the serious outcomes as low risk, like stroke and intracranial hemorrhage. So over time, this study also lost favor. Then we had the EGSYS2. It's also known as the Evaluation of Guidelines in Syncope Study Score for Syncope. This was a study that was prospective, a cohort study done in 14 general hospitals in Italy. They enrolled about 516 consecutive patients who presented with unexplained syncope. About half of them, or 260 of them, they used to derive the scoring system, and the next 256 patients they used to validate the scoring system. So they used, these were the criteria that they developed. It was like abnormal EKG, palpitations before syncope, syncope during effort, syncope in supine position, any autonomic prodromes, any predisposing or precipitating factors to develop the scoring system. And here you can see they had this Kaplan-Meier curve where they found that a score of more than 3 identified cardiac syncope with a sensitivity of about 92% and a specificity of about 69%. And they followed up this patient, I think close to about 2 years, and they saw that patients who had a score of more than 3 had a higher total mortality that was seen both in the derivation and the validation. So the first one here is the derivation cohort, and this is the validation cohort. Again, the study had its own set of limitations. It is limited generalizability, and the main reason was because they had a cardiologist specializing in syncope who was able to review the EKGs to make a determination, and that had a lot of weight in the scoring system. It included very specific criteria for what EKG abnormality should be considered. It followed the ESC guidelines. In terms of mortality, we have the OESIL-2 study. It's again another Italian study. They had about 195 patients who presented with a syncopal spell at the emergency department. It had mainly 4 components. It had the age more than 65 years old, any cardiovascular disease in the clinical history, syncope without any prodrome, or again, any abnormal EKG. They noted that the mortality at 1 year increased significantly as the score increased in the derivation cohort. So it went from 0% for a score of 0 to all the way up to close to 57% for about 4 points. And the same pattern they noted in their validation cohort of about 328 consecutive patients. So this OESIL-2 is a very common tool that has been used to predict what is the more long-term mortality of these patients. So they did a meta-analysis where they saw how the syncope risk stratification tools performed against clinical judgment. And they found out that this study was done in 2014, that the current prediction tools did not show any better sensitivity, specificity, or prognostic yield compared with clinical judgment in predicting short-term serious outcomes after syncope. It's a meta-analysis, so it was limited by the heterogeneity in the data. They were not able to get a lot of original data from the authors and the studies that they analyzed. But there are certain risk factors, if you see across all the scoring systems, that were noted to be consistently associated with an increased risk of adverse outcomes. So they included an acute coronary syndrome or symptoms suggestive of acute coronary syndrome, evidence of congestive heart failure at the time of presentation or a history of congestive heart failure, any history of structural heart disease, abnormal EKGs, anemias, or hemodynamic instability. The main problems that we saw, to kind of summarize from all the scoring systems so far, is they have problems with validation, generalizability. Most of the scoring systems did not consider what is the initial clinical judgment by the provider who first saw the patient. And there was no proper utilization of various biomarkers in any of the scoring systems, like the troponin and BNP. So this led to the development of the Canadian Syncope Risk Score, about which I'm going to go a little bit in detail. It was developed to predict the serious adverse events after emergency department assessment of syncope. This study came out in 2016. It was a prospective study done in 6 EDs in 4 Canadian cities. It included adults that were aged more than 16 years who presented within 24 hours of having a syncopal event from 2010 to 2014. They excluded patients who had a prolonged loss of consciousness, any change in mental status from baseline, any witness seizure, if they had any major trauma, any intoxication with alcohol, illicit drugs, or the patient had any language barrier. They define a serious adverse event as a detection or occurrence of any serious condition related to syncope within 30 days after the ED disposition. They included death, arrhythmias, myocardial infarction, structural heart disease, aortic dissection, pulmonary embolism, or any serious medical condition that caused syncope or any procedural interventions for that. So they did a structured review of the patient's health records, both inpatient, outpatient, operative notes. They reviewed all the results of various investigations, and they went through hospital death records. They had a scripted telephone follow-up immediately after 30 days for all of these patients. If you see here, they screened about close to 12,000 patients. They excluded about 5,800 of them due to various causes based on the exclusion criteria. They had a potential 6,000 patients that were eligible, out of which they excluded 1,800. Again, they mentioned the reasons here. In the final study, they had about 4,300 patients. They lost about 292 patients to follow up, and they included about 4,030 patients in the final analysis. So they saw what was the rate of serious events in all of these cases. And they noted that they had a total about 147 serious adverse events and 21 deaths. They divided what were the different cardiac serious events and the non-cardiac serious events. Then they went and did a multivariable logistic regression model to derive how they're going to get their scoring system. And these were the various variables that they were able to get from that. So using that, they developed a scoring system. So in the clinical evaluation, they use a predisposition to vasovagal symptoms, any history of heart disease, systolic blood pressure less than 90 or more than 180, if they had an elevated troponin, an abnormal QRS, a QRS axis or duration, QT intervals. But more importantly, they included what was the initial diagnosis that was thought when the patient presented to the ED, whether they felt it was a vasovagal syncope or a cardiac syncope. And then they estimated what was their risk of adverse events. And we can see here on my right, on the right-hand side here, that the patient had a total score of -3. It had only a 0.4% chance of a serious adverse event. And the scoring system went all the way down to 11. And with the score of 11, it had about a predicted 83.6% risk of having an adverse event. So this is the more simplified scoring system that they were able to develop. And this study, they validated the study, and this study came out in JAMA in 2020, this year, I think back in March. So what they did here was, after the initial recruitment, they went ahead and had another 13,700 patients that were screened. They excluded about 8,500 patients. They had about 5,000 patients that were potentially eligible. They excluded 1,000 patients because they were missed during the initial screening process. They had about 4,000 patients that were enrolled. In the final analysis, they had about 3,800 patients. So in this, they saw what were the 30-day serious outcomes for each risk category. And here was the total risk. The very low risk and the low risk, you can see they did not have any deaths reported, and they did not have any ventricular arrhythmias. And as the risk level increased, so did all the deaths and the arrhythmias from that. So in the validation study, they found out that the 30-day serious outcome during the validation was 3.64%, which was similar to their model predicted probability, which was about 3.17%. The 30-day serious outcomes increased from 0.3% the very low risk group to 51% in the very high risk group, and that was statistically significant. None of the very low risk or the low risk patients died or experienced any ventricular arrhythmias. So the authors concluded that the CSRS, the Canadian Syncope Risk Scoring, was successfully validated, and they recommended its use to guide ED management of patients when serious causes were not identified during the initial evaluation. They felt that very low risk and low risk patients can generally be discharged. That's those who had a score of -3 to 0, while brief hospitalization can be considered for high risk patients. So what are the main limitations of the Canadian Syncope scoring system, other than being done in Canada? It was done in academic institutions only, so not in general places where there are no academic settings. It was mainly done in the emergency department, so it cannot be applied to if a patient presents to the PCP's office. So what is the role of the cardiac biomarker? So if we can recall just what Dr. Kumar had mentioned earlier, the ACC and AHA guidelines has got a 2B recommendation for it, which means it is really, there is no evidence for that. That is usefulness and of BNP and high sensitivity troponin is uncertain in whom a cardiac cause of syncope is suspected. But recently there's a new study that came out, and it's one of the BASEL IX study. It was published in 2018. This is after the ACC and AHA guidelines came out. It's a still ongoing prospective international study. It's been done in across 8 countries, in Switzerland, and I think even the US is one of the centers. They had about patients that were aged between more than 40 years and presented to the ED with syncope within the last 12 hours. So here they did a clinical assessment for the patient. They followed the patient for 6, 12, and 24 months after discharge. And their primary endpoint is looking at what are the accuracy of BNP, pro-BNP, high sensitivity troponin T and I for cardiac syncope. The other primary, co-primary endpoints they were looking at was the accuracy of the markers to predict death or overall major cardiac event at 30 and 720 days of follow-up. So here, if you can see that in all cases of cardiac syncope, the markers were significantly elevated, and it was statistically significant compared to other causes of syncope. This also found out that the BNP or pro-BNP and the troponin performed better than the ROSE and the San Francisco scoring system that we spoke about. The BNP, pro-BNP, and the troponin T even outperformed the OESIL score to predict death within 360 days. But the most interesting part is that they found that the Canadian system outperformed all the 4 biomarkers in predicting death and any major adverse cardiac event. The limitations of the study was it mainly involved only the patients that presented with ED. The clinical utility of this is not known if the patient presented 12 hours, more than 12 hours after the syncopal event, or if the patient was less than 45 years old. There were no serial measurements of the biomarkers available, so they're not sure if the biomarker is trending up, if it had any significance or not. And it's a still ongoing study that is still, so I think they're expecting the next results in next year. So with this Canadian system, the authors tried to find out why there were barriers to implementation even in the places where they did their study originally. And they did a survey with the ED physicians, and they found out that the ED physicians were wondering about the lack of access the patient had to outpatient monitoring. There was uncertainty over the timely follow-up and care of these patients. There was always patient and family concerns, social factors, necessary blood work that need to be done for the patient. And they felt that if they had help with patient education, reassurance, and optimal patient factor, like if the patient was reliable, they had enough adequate support at home and fewer comorbidities, they would be able to implement this scoring system better. So with that, we'll come back to our original cases, and I give it back to Dr. Adunse.
All right, thank you, Dr. Verghese and Dr. Kumar. Hello again, everyone. So, listen to very, interesting studies. We've gone through syncope. Also gone through some risk stratification scoring systems, and so we're going to try and recall our last 3 cases, and we're going to go on to resolution. So, case 1, if we remember, was the case of the 75-year-old male that had a history of thyroid disease, and he did have some cardiac history. If we look at the scoring system here, the Canadian Syncope Risk Scoring calculator, when the patient came in, he was scored a -1 for predisposition to vasovagal symptoms. The history of heart disease too gave him a +1. And then, you know, the other variables here, he scored a no. The ED physician, you know, based on this cumulatively, he had a score of 0. So, you know, -1 + 1, you know, our math is 0. So even though this patient had, you know, significant cardiac history, based on his history, and as Dr. Kumar alluded to, you know, based on the class of recommendation, which is a class 1 for history and evaluation, you know, that helped to come to this assessment. So this patient, you know, is felt to have a low risk, exactly, you know, less than 2% risk of serious adverse events in 30 days. So this patient could safely be discharged, you know, with close monitoring as an outpatient. And based on the poll, most of us were going to admit this patient. And, you know, like we said earlier, clinical judgment is a big tool here too. So, you know, I understand why physicians will want to admit this patient, but, you know, based on the scoring system, we could safely discharge this patient home with close outpatient monitoring. So, discharge. Case 2 was our most complicated case with a 95-year-old male with a gamut of cardiac, you know, issues. You know, and the poll, 91% of us were going to admit this patient. And here, based on the scoring calculator, he slumped, you know, in front of the table. So that, you know, wasn't clear-cut in terms of vasovagal symptoms, so it was scored a no. History of heart disease +1. Elevated troponin, we got a +2 for that. And in the ED assessment, cardiac syncope was felt to be the cause, and he was given a +2, and he scored 5 points total on the scoring calculator, which makes him a high risk, you know, about 19%, you know, risk of serious adverse events in 30 days. So he was admitted for further workup. And then case 3 was a relatively benign case of a 30-year-old female who, you know, passed out in the toilet or the bathroom. And based on the scoring calculator, predisposition to vasovagal symptoms, she got a -1, you know, benign. She scored a 0 for most of the other variables. And in the ED, she scored a -2 for vasovagal syncope. This patient, if we remember, had a significant family history of sudden cardiac death in her dad at the age of 40, relatively young. So based on the poll, well, almost everyone was, or most of us were comfortable sending this patient home, and rightly so. She could be followed up, you know, as outpatient as well. So the resolution was discharge. So in summary, not all loss of consciousness is syncope, as Dr. Kumar alluded to. So a very good history will be required to, you know, to rule out other causes of loss of consciousness. The most common is the reflex syncope, neurally mediated syncope. Cardiac syncope has worse outcomes than non-cardiac syncope for obvious reasons. History and physical exam are key to evaluation of syncope. Like we mentioned earlier, Dr. Kumar mentioned earlier, it's a class 1 level recommendation. The use of the risk stratification scores may be a reasonable tool in the management of patients with syncope, and that was a class 2B, if I rightly remember, for the class of recommendation. And the Canadian Syncope Risk Score calculator at this time seems to be the most useful tool based on the studies, you know, Dr. Verghese talked about. We do recognize the limitations of stratification scores and are acknowledged, but, you know, as physicians, we tend to, you know, get patients, especially in the inpatient setting, we have patients that come in like the 30-year-old female, and then the ED physicians, especially with our family history, we want to admit these patients. But when we as hospitalists take over the care of the patients, sometimes we have the patient saying, I don't know why I was admitted in the ED. I'd like to go home. We may sometimes be on the fence about admitting such patients, but if we use this tool, I think I'm going to be using it myself. If we use this tool, we can decide to send the patient, home for close outpatient monitoring, especially with the kind of relationship we have with the PCPs. We can, attempt to do this and see how things go. So in conclusion, the judicious interpretation of clinical presentation, our clinical, knowledge and acumen, and the Canadian Syncope Risk Score may help avoid unnecessary and costly workup for low-risk cases of syncope, which is what we're hoping to achieve. I would like to try this in my clinical practice and see, and check with my colleagues, Dr. Verghese and Dr. Kumar, and see if we're able to make any strides. Thank you very much for your time, attention, and patience.
So there are a couple of questions. Dr. Chaudhary asks about pulmonary embolus. He says that a study showed 17% of syncopal episodes can be from pulmonary embolus. And when do you consider getting a D-dimer level in these syncope patients?
Thank you for asking that question. That is a very common thing that I think that study was done. It was a 2016 study that was done, and it had a high estimate of patients that had unexplained syncope, and they said that they had syncope was due to pulmonary embolism. But I think that original study had a lot of flaws in it. That study, what it had initially done was they had excluded a lot of patients that initially presented to ED with syncope, and then they had discharged the patient home. So those patients were not used in the analysis. And subsequently in 2017, there was another study done where the incidence of syncope in those cases was noted to be much lower. I think the original, it has about 3.7%. And in 2018, there was another study that came out. And in that, the true incidence of pulmonary embolism in syncope was estimated to be only 0.2%. Of course, as we know, the pulmonary embolism is a great equalizer. It has got very, very atypical presentations. So yes, certainly that should always be in the back of our mind. But if we use these scoring systems, we may help guide better our decisions.
And then there's a question from an anonymous person, I guess. Are there any data on short-term ECG monitoring that is for 24 hours? And does that alter predictive measures of risk?
So I think based on the recommendations I reviewed from ACC, they did mention use of outpatient or prolonged ECG monitoring.
You have to get closer to the mic. It's hard to hear.
They did mention the use of outpatient Holter monitoring or prolonged ECG monitoring, but in patients who only presented initially with suspected cardiac syncope, not in patients non-suspected or any other type of syncope, and who don't have any previously known cardiac disease or something like that. So it seems like patients who are initially labeled as unexplained syncope and obviously they need more workup, yes, the Holter monitoring or prolonged EEG monitoring is one of the tools which we can use in prolonged setting.
So I know you're not looking to talk about management, but some of these patients who are at high risk for cardiac events at 30 days, and you know that based on the risk factors, should they be prospectively getting a pacemaker defibrillator, or do you wait until a full cardiac workup is done?
I guess we should do the workup and determine the cause, what caused that syncope, and then if the cause was actually arrhythmia, and then based on the recommendations for current guidelines, yes.
Right. Sometimes you don't find anything though, right?
It was actually mentioned in the recommendations, like ACC guidelines, that implantation of the pacemaker or ICD is one of the treatment options for patients who actually need it.
All right, there are no further questions online, and we're at 9:30. So thank you very much, guys. Great job, nice presentation, and see everybody next week. Thank you.
Thank you.